And we have CME credit hours for the Indian nationals. So today we have the most eminent moderator, Dr. Amrish Jain, who is also our course director. And he is a medical director, pediatric kidney transplant program at Children's Hospital of Michigan, USA. And he has got a lot of awards to add on. He has won the Best Teacher Award for the year, which was voted by the Children's Hospital of Michigan by pediatric residents. And so he is a best teacher from the students' perspective. So nomination for excellence in teaching in pediatrics, award nomination by the colleagues for exemplary teaching at CMU College of Medicine. And he has also been rewarded as a top nephrologist, peer review survey by the physician honoring the adult and the pediatric nephrologist in Metropolitan Detroit, MI. And there are a lot of national and international publications to add on. So over to Dr. Amrish to introduce the speakers of the day.
Yeah, thank you, Dr. Kalayani. It has been a pleasure to be part of this webinar, 5th year in row. I think this gives us an opportunity to interact. This has been a very international collaboration, and we get a lot of international attendees. And one of the highlights of this session is that I get to meet my old friends, when we are doing these webinars, and then definitely my new friends who I make while we are doing these sessions. So it is my pleasure and honor to introduce my dear friend, Dr. Anil Vasudevan, who's the professor in the Department of Pediatric Nephrology and adjunct professor in Division of Molecular Medicine at St. John's Research Institute and St. John's Medical College Hospital, Bangalore. As we know, he did his fellowship from Sick Kids Toronto, and that's where he developed his interest in genetics of kidney disease. And his talk today is going to be focused on genomics of chronic kidney disease. Besides that, he also has interests in acute kidney injury and low-cost devices for dialysis. He has been a very active member, be it International Peds Nephrology Association, be it Asian Society of Pediatric Nephrology, Indian Society of Pediatric Nephrology. He has been part of a number of committees and task force. And to highlight, he has been part of the evidence-based guidelines for nephrotic syndrome, HUS, AKI, and COVID-19 with IPNA and Indian Society of Pediatric Nephrology. He has been part of of competence-based syllabus in pediatric nephrology, and he has had more than 50 publications, more than 20 book chapters on various kidney disease topics. Again, it's my pleasure to have you here, Dr. Anil, and we are looking forward to your talk. Over to you.
Thank you, Dr. Kalai, and Dr. Amrish for the generous introduction. And congratulations for running this webinar series for the 5th consecutive year, which is quite popular among both the residents, the trainees, and the faculty. So the topic for today is genomics of CKD, and I've kept this simple, considering the audience in mind that basically they are the trainees or fellows training in pediatric nephrology. So you must have heard in the initial sessions that because my internet connectivity is a little weak, I'm just switching off the video. So you must have heard in the initial session about the burden of CKD and how it's associated with significant morbidities and mortality, an accurate diagnosis, establishing prognosis, and individualizing treatment are limitations when we talk of CKD. And to that end, genetic evaluation is becoming an important tool in our armamentarium to mitigate many of these challenges. And I will be using some case scenarios, and I'm quite lucky to, to learn a lot when my clinical colleagues share the reports for interpretation and opinion. And these reports are for educational purposes. I will be briefly starting with the overview of the genetics of kidney disease and some basic aspects of the genomic assessment in the context of CKD, and then use case scenarios to examine the integration of this genomic assessment in the clinical workflow. And finally, come to the challenges and barriers while using a genomic assessment in the setting of CKD. So as we know, CKD could be because of a genetic cause, or because of some environmental or acquired causes such as infections, medications, and so on, or also a combination of both, where an environmental insult in the background of a genetic susceptibility could lead to a chronic kidney disease. And with the advent of high throughput genotyping and massively parallel sequencing methods, and also availability of large data sets of genomic and health information, it has led to a better understanding of the genetic basis of not only the kidney disease, but also kidney function. So when we talk of monogenic kidney diseases and complex kidney diseases, the monogenic refers to diseases caused by rare variants, rare pathogenic variants in single gene. And here the genotypic phenotypic relationship is very strong, and the environmental influence is very limited. On the other hand, the polygenic or the complex kidney disease do not have a simple inheritance pattern, like as you see in monogenic. It could be an autosomal recessive dominant or a sex-linked dominant or recessive. Here, you do not have a particular inheritance patterns. Instead, it is a combination of the of a combinatorial effect of many common variant in multiple genomic loci, and in addition to the environmental factors that results in the kidney disease. In a clinical setting, we generally evaluate for a monogenic causes, although there are a lot of research that has been done in identifying multiple genetic susceptibility factors, which are mainly single nucleotide polymorphisms in various diseases such as IgA nephropathy, membranous nephropathy, nephrotic syndrome, and so on, and also looking at the inheritability of certain functions such as the GFR and also the proteinuria. But since the clinical applicability is limited, I'll be more focusing on the monogenic aspect. We all know that the knowledge of the genetic etiology of chronic kidney disease accelerated with the mapping of the human genome, plus the advancement in the sequencing technique. As of now, we know that there are more than 600 Mendelian disorders associated with kidney and neurological traits. There are more than 600 genes that have been implicated in various monogenic kidney diseases. And this cartoon highlights the genetic heterogeneity within these subgroup of diseases. And the genetic codes accounts for nearly half of the cases of severe CKD in children, and up to 1/3 of the CKD in adult. Of course, the proportion varies with the kind of population that we are screening and the kind of a kidney disease that we're looking at. So when we talk of a genetic evaluation, we need to remember that it's a multidisciplinary team approach, where after a nephrology consult, we need to consult a genetic specialist and then decide whether a genetic evaluation is worth it, and then order those tests, receive the test, and take it back to the patient, interpret it, and counsel them. But as we know, the genetic specialists are not easily available in many parts of our country, and it remains up to the nephrologist to do this part. And it is also a multi-step process where it begins with identifying at-risk patients, providing the pre-test counseling and informed consent, or selecting and offering the test, and then receiving and disclosing the result, followed by post-test counseling. In this process, I'm going to discuss 3 key aspects of whom do we test in the setting of CKD, what kind of a testing method do we use, and how is it going to be useful. So the probability of a monogenic etiology is very high when a child when the CKD presents very early in life, or it presents with a severe form, where there is a history of family history or consanguinity. When in certain patterns such as cystic kidney disease or in a primary steroid resistant nephrotic syndrome, which has a significant proportion of a genetic etiology, we need to consider it. And also when there is extrarenal or syndromic manifestations. There is also a role of genetic testing when we do not have a clear-cut clinical diagnosis of the underlying CKD, especially in a country where these children present very late. We cannot use other tests such as kidney biopsy to have a diagnosis, and genetic testing can be useful in these situations. Before I go to what kind of a genetic testing method I choose, I just want to highlight 3 important points. First is that The yield of genetic testing varies with the kind of disease that we are looking at. And second, there is a significant genetic heterogeneity even among these subgroup of chronic kidney diseases, whether it's a glomerular, tubular, or a stone disease, cystic, ciliopathies, or CACUT. A analysis of multiple studies has shown that the yield of genetic testing varies between these subgroups, not only within these subgroup but also between children and adults. So, for example, the maximum yield of a genetic testing is with renal tubulopathies and with Alport syndrome, whereas it is around 25% in steroid-resistant nephrotic syndrome and in stone disease, whereas it is least with congenital anomaly of kidney and urinary tract, which is actually a developmental anomaly. But however, a genetic testing yield is much low as compared to other groups of diseases. And overall, the genetic yield is lower when you come in adult onset CKD as compared to a childhood onset CKD. But there are certain conditions which are not usually encountered in children, such as autosomal dominant tubulointerstitial kidney disease, which is more or less seen in adulthood. And also, this genetic yield can vary with the population we are studying. For example, in our study of tubular disorders, where we performed massively parallel sequencing in more than 130 children with various tubular disorders, the outer circle shows the clinical diagnosis, and the inner circle with the darker square shows the genetic yield. As you can see, our genetic yield was close to 60% in distal renal tubular acidosis, around 70% in Bartter syndrome, around 30% in stone forming disorders. And these prevalence is much lesser as reported in other populations. And mainly because most of the variants are novel, we do not have much functional information about these variant. Hence, they are categorized as variant of unknown significance. Similarly, in our study of using genetic testing using a customized gene panel, in this case, in children with CACUT, we did not find any genetic etiology. And this could be possibly because our cohort was enriched for those with lower urinary tract dysfunction, such as reflux, posterior urethral valve, and so on. So as you can see here, not only the disease category, but also the population can influence the genetic burden that you identify while using genetic testing. The second point is that CKD is characterized by significant phenotypic heterogeneity. For example, podocytopathy caused due to a podos in NPHS2 gene. You can have a child presenting with a classical nephrotic syndrome that is steroid resistant, or an older child who has only proteinuria without other features of nephrotic syndrome, or the child could present directly in chronic kidney disease. And also, this nephrotic syndrome also could be due to other etiology, which could be genetic, such as an Alport syndrome, or could be non-genetic, such as IgA nephropathy or membranous nephropathy. The other aspect is that the use of this massively parallel sequencing testing has uncovered the expanded phenotype. And I'm showing an example of a congenital anomaly of kidney and urinary tract, wherein the variant in the Fraser complex that consists of 3 genes plus another gene called the GRIP1, where you can have different manifestations, varying from syndromic manifestations to isolated CACUT, based on the kind of variant that you've identified. So if you have truncating variants in any of these, biallelic truncating variant in any of these genes, it results in a syndromic manifestation. Whereas if you have missense variant in these genes, it could result in a more of a limited phenotype that could also be just an isolated CACUT. So this becomes very important in the third point that I'm raising, that is phenotyping. So increasingly, we are being over-enthusiastic to use genetic testing without complete phenotyping, and we could land up with various challenges. Hence, it's very important that before we order a genetic test, we do the complete phenotyping as much as possible. That includes a detailed clinical history, the family history, and also when we are relaying this information to while ordering the test, we need to avoid just mentioning the diagnosis that we think, but we put the entire clinical description and also all the additional information, including the biopsy finding and laboratory finding. Because the granularity of the clinical information that we provide helps in the interpretation of the variant. I've given an example of, the granularity in the case of a nephrogenic diabetes insipidus, where you not only gave the clinical features, you also mentioned the key laboratory profile, and also the results of your water deprivation step, because interpreting the variant involves two components. One is assessing the variant pathogenicity using a set number of criteria as per the ACMG criteria. The second is to make the class level interpretation, where you need to correlate the variant with the phenotype of the child. And here the complete phenotyping becomes very important in assessing the clinical relevance of the variant identified in the genetic testing. So with this three important points, now we move on to the next step of how do we choose the genetic testing method. There are many factors which influences the choice of the method, and that includes accessibility, cost, but more importantly, it's the type of variant that you are expecting to be for the cause of the underlying CKD. For example, if it's a syndromic child where you're suspecting a chromosomal anomaly, you order a karyotyping. If it's a large deletions or insertion that involves more than 1,000 base pairs, then we need to order the microarray or a complex genomic hybridization. If these large insertion or deletions are limited to a set number of genes, then we ask for a multiplex ligation dependent probe amplification. But most commonly in a clinical setting, a single nucleotide variant or small insertion deletions, that is involving less than 1,000 base pairs, are commonly associated with the genetic causes. And here we could use a Sanger sequencing, or what we now commonly use, the massively parallel sequencing, which was formerly called the next generation sequencing. Again, we have a lot of choices among these next generation sequencing method, and this includes a panel which could be specific for a disease. For example, a steroid-resistant nephrotic syndrome panel, a hemolytic uremic syndrome panel, a cystic kidney disease panel, or it could be an organ panel, like a kidney panel, where, as I said, there are more than 600 genes associated with various kidney disease, and you include the most common 300 or the 400 genes in this panel. On the other hand, you have the clinical exome, or the Mendelium, which includes all the genes that have been mapped to any disease, which can be kidney or non-kidney related diseases. And you have the whole exome, where you are sequencing all the 20,000 genes, many of which we do not have any idea about which kind of a disease that could cause if there are any abnormal variant. So in a clinical practice, we do not use a whole genome sequencing. That is more of a research domain when we do not get any yield in any of these tests, and we are strongly suspecting a monogenic etiology. So commonly we use a clinical exome or a whole exome, and if we are very certain about the clinical diagnosis, we could even use a panel. An advantage of using a whole exome is that we could also identify copy number variants, which otherwise will require an array or an MLPA. The Sanger sequencing is limited to either confirming a variant identified in this exome sequencing, or if we already know the genetic diagnosis in a familial setting, or while doing an antenatal testing. The role of MLPA is very limited in setting of CKD, when in conditions such as HUS, or in certain settings as nephronophthisis, or even in Alport syndrome, where the conventional exome sequencing did not identify a variant, but the clinical features strongly suggestive of Alport. It has been found that around 10% of those who are negative by exome sequencing, we can identify the variant using an MLPA method, looking at all the called 4A3, 4A4, and 4A5 genes. So how does this genetic testing help us? It helps us in a number of ways, especially in confirming a diagnosis or making a diagnosis when you have a CKD of unclear etiology. It helps also in identifying children who require additional screening for extrarenal manifestations such as an HA1 beta, where the child can develop diabetes later on, so they need to be on surveillance. They can develop hypomagnesemia and hyperuricemia, which can be only picked up by laboratory evaluation. We can also identify conditions that are amenable to specific disease-modifying therapy, such as CoQ10 and steroid-resistant, histamine therapy in children with cystinosis, and so on. We can also the genetic testing can also help us avoid unnecessary immunosuppressive therapy. For example, a child presenting with a so-called nephrotic syndrome who's turned out to be steroid resistant, but may actually be a phenocopy of Alport syndrome. Genetic testing also helps in transplant planning, like in predicting recurrence kind of transplant, because in certain condition we may require a combined liver kidney transplant, such as in primary hyperoxaluria type 1, in complement factor H, variant in AHUS. And of course, all this genetic testing can also help in reproductive counseling. So now we will look at some case scenarios. And before that, I just want to, this is a study that was done in China, published few years ago, to highlight the diagnostic and clinical utility of genetic testing in children with presenting with end-stage kidney disease. So they looked at the genetic results of 188 children over the 10 years. And they used a combination of testing methods, right from targeted panel to whole exome sequencing. What they found was that around 40% of them, they could identify genetic diagnosis, most commonly in steroid-resistant nephrotic syndrome, Alport, celiopathy, and in stone diseases. And not only helped in confirming diagnosis, around close to 10%, they were able to revise their clinical diagnosis, and in another 7%, they could diagnose an undiagnosed condition. In addition, the genetic testing was also useful, wherein 1/3 of them, they avoided a kidney biopsy. And it also helped in individualizing the treatment, either it be a specific treatment or negating the need for immunosuppression. In 2/3 of these children who had a genetic diagnosis also required surveillance for extrarenal features. And also 1/3 of them, they could identify additional family members who had a similar disease. So this study shows the power of genetic testing and the utility in a setting of chronic kidney disease. And I want to highlight this aspect of the utility, especially when we have unclear diagnosis, especially in our country. As I said, it's very common that these children are picked up late and in very advanced stage of CKD because of lack of awareness both within the family as well as with the clinician. So this is a child, adolescent, who was referred much later with a diagnosis of ESKD, probably 5 years after the diagnosis. The kidneys appeared very small with loss of CMD. There was no family history of CKD. She was anuric, was initially on HD, but developed refractory, cardiac failure, very difficult to manage. The child later switched to CAPD. And as part of the transplant workup, we performed an MCU because this was a CKD of unclear etiology. And to our surprise, we noticed calcified kidneys. That gave us a clue that probably this is a child with hyperoxaluria. And this was probably more than 1.5 decades ago, where next generation sequencing hadn't come in. So we relied on Sanger sequencing the 3 genes associated with hyperoxaluria. And we found a compound heterozygous that segregated in the parental screening. And a diagnosis was confirmed, which not only helped us to step back in a pre-transplant workup, because now this child needed a combined liver kidney transplant. So hence, it is very important to consider genetic testing in unclear etiology. This is another child, an adolescent again, who presented with poor appetite, poor growth, lower limb deformities noticed since last 3 years, had genu-valgum and hypertension, already was in stage 3B when they presented to us. And this is a very common scenario that we face. The ultrasound showing a normal sized kidney with poor corticomedullary differentiation with some cysts. And the other parameters does not give us a clue, including the screening for extrarenal symptoms. So one of the first studies that highlighted the utility of genetics testing in such a scenario was from Germany, where they sequenced using a whole exome sequencing approach in 79 families with normal size kidney with increased echogenicity. And what they noted was that more than in 2/3 of them, they could identify a genetic etiology. And of these 2/3, the most common was a nephronophthisis-related celiopathy. The other common genetic etiology were Alport syndrome and autosomal recessive polycystic kidney disease, again suggesting a significant genotypic and a phenotypic heterogeneity. So in our child, because we had no clear idea of what the child has, we sent for a clinical exome sequencing. We identified a biallelic pathogenic variant in NPHP4 gene, and in this with this genetic condition, almost 25% may have eye anomaly, especially a retinitis pigmentosa. But however, on screening, this child did not have, the eyes were normal. A small subset can also have liver abnormality, but even here, the child had a normal liver, both by imaging and by liver function test. So clearly, genetic testing has a role, especially in a setting of CKD of unclear etiology. What about in those setting of CKD, where even you do a biopsy, but the biopsy also is proven inconclusive? So this is an adult study that looked at genetic setting in 52 patients with biopsy proven unknown kidney disease. As you can see here, they clinically categorized very broadly into glomerular, tubular, interstitial, vascular, and unclassified. When they did an exome sequencing, they identified a monogenic cause, 40% of these patients. And most common, again, were Alport syndrome or podocytopathy or a celiopathy. So clearly, again, showing that in certain situations, especially where biopsy is inconclusive or you cannot do because of a high risk of bleeding and other risk factors, a genetic testing can be often useful. So this is an algorithm that has been proposed 5 years ago by KDIGO, where if you have a kidney disease of unclear etiology, you look at the probability of an underlying genetic etiology based on these clinical factors. If these are present, the probability is high. And you do an exome sequencing. If and the exome sequencing is negative, probably a chromosomal microarray, or a chromosomal microarray directly if you think of the likelihood of a copy number variant. Even if you have a positive result, it is very important to have to look for the concordance with the clinical presentation. If there is no concordance with the clinical presentation, or if there's a negative result or a variant of unknown significance, then you need a multidisciplinary consult to decide on further workup. It could be reviewing the phenotype, looking at additional genetic testing, including transcriptomic sequencing, and also to remember that these group of children of this genetic testing where you get a VUS, we need to do a periodic analysis of the exome sequencing data. So what about the utility of genetic testing in whom there is a definitive clinical diagnosis? For example, an autosomal recessive polycystic kidney disease. They have a characteristic salt and pepper appearance of the kidneys right from the fetal life, and the kidneys are very large with also a liver, liver ecotexture. Now, the utility of genetic testing was identified in the ADPEG registry, where nearly 11% of those clinically diagnosed as ARPKD turned out to be not ARPKD by genetic testing. As you can see, and of these children who did not have and who were not confirmed as ARPKD by genetic testing, more than half, close to half of them had a salt and pepper appearance on ultrasound, and 90% of them had large kidneys. But genetic testing helped us identify that almost 50% of them had variant in PKD1, which causes an ADPKD, and rest of them had variant in genes that caused either a celiopathy or HNF1 beta. Again, here, indicating that we should go for a genetic testing as much as possible, even when we are pretty sure of the clinical diagnosis, but because that has many implications. So one of the utilities has been in confirming the diagnosis and also identifying the phenocopy. When we say of phenocopy, actually refers to a genetic disease which mimics an acquired environmental, disease caused by an environmental factor. But here we are referring to genetic diseases that are caused by different mechanisms. Example, a podocytopathy versus an Alport syndrome where the glomerular basement membrane is involved. The utility of genetic is this testing and in identifying phenocopy and revising the diagnosis is highlighted in our study, again in children with tubular disorders, where in around 10%, we were able to revise a clinical diagnosis. For example, a child clinically diagnosed with DRTA turned out to be either hyperoxaluria or HNF1 beta associated kidney disease. Similarly, we are able to confirm the etiology in 4 children who did not have a clinical diagnosis. It was a DRTA in 2, gentlemen in 1, and so on. So clearly, the genetic testing helps in identification of a phenocopy and revision, even in setting where we are very sure we have found the clinical diagnosis, especially in glomerular disease. Like in this child, a very young child presented with something like a nephrotic syndrome, but also had seizures during infancy. The kidney biopsy showed FSGS of not otherwise specified. The EM showed, the contours of the glomerular membrane were thin and thick, exactly like mimicking an Alport syndrome. So you can be sure that your genetic testing is probably going to yield a variant in one of those Alport-related genes. But what turned out was a biallelic heterozygous variant in an TRIM8 gene, which is associated with FSGS and neurodevelopmental syndrome. Similarly, in case 2, an adolescent child who presented 5 years ago with instantly detected subnephrotic proteinuria, clinical evaluation was not fitting into nephrotic syndrome, where they were lost to follow-up, presented 5 years later with worsening proteinuria. There was a family history of renal calculi. Again, a kidney biopsy was performed, which showed some mild increase in mesangial hypercellularity. The immunofluorescence was unimpressive. The EM again here showed significant effacement of food process and also irregular contours, a classical basket weave appearance of the GBM, again indicating that it could be potentially an Alport. But a genetic result was surprising. It identified a compound heterozygous variant in the MYO1A gene, which again is involved in maintaining the integrity of the glomerular basement membrane. And this heterozygous variant segregated in parental screening. As I've shown in these 2 cases, even when we have a very certain diagnosis based on a biopsy, a genetic testing is still useful to uncover the phenocopies. Another aspect of genetic utility is to identify extrarenal features for monitoring and surveillance. In a child with CKD, for example, a child who presented with nephrotic syndrome, biopsy showed FSGS, had a quick progression of the kidney disease, were presented in stage 4 within 3 years of the diagnosis. The genetic testing revealed here on examination, except for failure to thrive, otherwise the features were unremarkable. The genetic screening found to have a heterozygous variant, an intronic variant, which was likely pathogenic. And this variant results in what is called a Fraser syndrome, where they can have an ambiguous genitalia and also a gonadal dysgenesis with risk of gonadoblastoma. So we did a reverse phenotyping. However, the ultrasound, the karyotype was XX. The ultrasound was inconclusive. However, many years later, around 5 years later, when the child reached ESKD, and we were putting the CKD catheter, the surgeons identified gonadal dysgenesis and hence were removed. And this, we kept a high index of suspicion to look for the gonads only because of the genetic testing results. Genetic testing also helps in the kidney transplant setting, and especially when the child progresses to end-stage kidney disease, especially in confirming the diagnosis, if the diagnosis was unclear initially to begin with, helps in predicting recurrence, surveillance for extrarenal manifestations, and also planning the type of transplantation. In addition, it can also help in selecting a safe donor, especially in genetic condition that is associated with autosomal dominant inheritance. So this is a case study just to highlight the importance of and the utility of genetic testing in a setting of primary steroid-resistant nephrotic syndrome, where this is a family with 2 siblings having steroid-resistant nephrotic syndrome. Both of them were identified to have a biallelic pathogenic variant in the NPHS2 gene. And also the mother was screened and was found to be a heterozygous carrier. Being a recessive in inheritance, the mother was safe to donate to the child. And in addition, the genetic testing helped in predicting the recurrence because if there is a identified genetic etiology in the primary steroid-resistant nephrotic syndrome, the recurrence rate is very low. as opposed to those without a genetic diagnosis where the recurrence rate is very high. Hence, a recommendation is to obtain a genetic testing in children with primary SRNS who progresses to end-stage kidney disease. If not done earlier, at least to do it at the time of planning for the kidney transplant. Similarly, genetic testing is also useful in predicting the recurrence, stratifying the recurrence risk in children who have AHOS and have ESKD. As we know, the recurrence is very high when you have variant in complement factor H, C, and B, while it is the least when you have variant in a membrane cationic protein or the CD46 and DGKE. In another situation where the genetic testing is useful is determining the transplant approach. We know that many of the kidney disease require combined liver kidney transplant, such as in hemolytic uremic syndrome, atypical hemolytic uremic syndrome with complement factor H deficiency or primary hyperoxaluria. But another condition which is often not recognized is ciliopathy, especially nephronophthosis associated kidney disease. Because what the recent data from France has shown, which looked at more than 600 patients of ciliopathy, in whom they could identify a genetic etiology in 71%, and the common genes are listed here. What is interesting to know is that liver involvement can be quite significant, up to 70 to 80% with genetic variants such as in WDR75, in NPH3. So here we need to be cautious when we are counseling for kidney transplant, that there is a potential that even the liver disease can progress and may require liver transplant in future. So while I describe the utility of genetic testing in genomic assessment in the setting of CKD, there are bottlenecks. Our ability to sequence has far exceeded our ability to correctly interpret the variant. And hence, a lot of these variants have been as variant of unknown significance, where we need to be careful. We need to use our clinical judgment, consider discussion in a multidisciplinary team. We need to order further tests or additional investigations within the family or beyond the immediate family members. But we need to remember that we cannot use this for antenatal counseling or screening at risk. And also very important that we need to reanalyze these results periodically, every 6 months to 1 year. In addition, there are other technical challenges, especially that in condition like ciliopathy and Alport, where you find variant in more than one gene. And also, and especially when you're using a clinical exome or a whole exome, you could identify variant which are incidental or secondary. And this leads to a lot of social and ethical challenges. Fortunately, the cost of testing has significantly decreased. It is now affordable for most of our patients, but yes, also, and in fact, it's sometimes cheaper than the other expensive testing that we do, such as an immunoglobulin profile or a MRI or a CT scan. The other is this confusion between a clinical diagnosis and a genetic diagnosis. There is an increasing need for having a unified disease terminology, especially when you have a broad clinical disease such as ADKD, which is caused by a number of genes. So you could have a didactic presentation where you qualify the disease with the gene in which the variant has been identified. Similarly, there can be a very heterogeneous disease such as in CACUT, which is caused by PAX2, where they can have a syndromic and isolated CACUT. The isolated CACUT could be hyperdysplastic or a VOR and so, or a single kidney and so on. So a PAX2 kidney disease may be a better way to address that rather than calling it as a CACUT. And so Alport syndrome, as we know, that there is an expanded phenotype, including a cystic manifestation of Alport syndrome. And it could, the existing naming of these, such as Alport syndrome, could be modified in future as collagen 4 associated nephropathy or an Alport related nephropathy or Alport kidney disease. In a clinical setting, there are other channels like when to pursue and when to avoid unnecessary genetic testing. There are no uniform guidelines available. Interpretations of the genetic variant in healthy donor candidate, especially if they are autosomal dominant inheritance pattern or variant of unknown significance. And decision making when genetic testing yields no variant, with a strong suspicion of a monogenic disease. When we have multiple variants in more than one gene, which is not unusual in setting of ciliopathy, in stone disease, or in cystic kidney diseases. And overall, and over this is the physician knowledge gap, especially about the advantages, the limitations, the interpretation of the results, because we don't have a curriculum as such, and of course the patient and their family voice of their understanding of the genetic testing. And these are some of the challenges that we need to address. So in summary, the deployment of genetic testing in the diagnosis and management of CKD is becoming a part of mainstream practice. But we need to make sure that there's adequate pre and post-test counseling to understand the risk as well as the benefits. And also there is a need to educate the nephrology community regarding the testing indications, tools available, limitation of testing, and counseling approaches. Thank you.
Yep. Thank you so much, Dr. Anil, for making this complex topic so simple for our learners. We'll definitely have a question answer session at the end of the second talk. And our second speaker for today is Dr. Melissa Gregory, and I'm again honored and privileged to introduce her today. She is a long-term colleague of mine here at Children's Hospital of Michigan, and I have learned so much from her, especially when it comes to chronic kidney disease. She is the medical director here for the chronic kidney disease program, and she is also the co-director of the tuberous sclerosis complex clinic here at Children's Hospital of Michigan. She's associate professor of pediatrics and pediatric nephrology at Central Michigan University. As we talked about, her academic interests are pediatric chronic kidney disease, nutrition in chronic kidney disease children, tuberous sclerosis complex, and nephrotic syndrome. She has won Excellence in Teaching Award at Wayne State University. She has been nominated for years for the R. Detroit Top Doc Award. She also is the chair of CMU, Central Michigan University Institutional Review Board, and she guides most of our studies, making sure that we are in compliance. She is also a recipient of Pediatric Scientist Training Award at National Institute of Health, and her research experience is a good guide for all of us here. And she's part of the Scientific Advisory Committee of National Kidney Foundation. It is a pleasure again, Dr. Gregory, and over to you.
Thank you, Amrish. Dr. Jain asked that I speak about anemia and chronic kidney disease. Can we pass? When we talk about anemia, there's a very specific definition of it, and it's based on hemoglobin, not hematocrit, because hemoglobin is an actual measured value, while hematocrit is an estimated value. It's a calculated value, and it can be altered depending on volume, status, if there's a lot of lipid in the blood and things like that. So the anemia that we see in chronic kidney disease is normocytic, it's normochromic, and hypoproliferative. Basically it's due to secondary erythropoietin deficiency, although there are a lot of other factors that go into it. And it's associated, like all anemia is associated with poor outcomes, specifically a decreased quality of life and increased mortality. It's common. Doesn't usually start to occur until people are in stage 3 chronic kidney disease, so where their GFR is less than 60. It's twice as prevalent in chronic kidney disease as in the general population, and the incidence varies with different stages of chronic kidney disease. It's 73% in stage 3, and it's greater than 93% in stage 5. And if people on dialysis, almost everyone is anemic. This again just is a visual demonstration of how the incidence of anemia increases with decreasing GFR. And again, so the complications are there's increased cardiovascular events even in pediatric patients, increased risk of mortality, decreased quality of life due to increased hospitalizations, reduced exercise capacity, and most concerning in our patient population is there's an increased prevalence of neurocognitive problems in children with anemia. As I said, the basic etiology of anemia and chronic kidney disease is decreased production of erythropoietin. There are multiple other factors. There's abnormal iron metabolism due to chronic inflammation, which is usually associated with chronic kidney disease. Uremia causes red blood cell deformity and increases the risk of hemolysis. There's increased bleeding due to dysfunctional platelets. This is especially true in our adolescent female population who may have really very significant menorrhagia associated with their chronic kidney disease. nutritional deficits are very common in children and adults with chronic kidney disease. And so folate and B12 deficiencies can be common. And there's also a downregulation of the hypoxia-inducible factor, which is a trait that regulates gene expression of erythropoietin. So erythropoietin is made by interstitial cells, the peritubular type 1 interstitial cells of the renal cortex and the outer medulla. Increased production of erythropoietin is associated with increased proximal tubule sodium reabsorption, because the proximal tubule is the part of the kidney that needs the most oxygen. And the reabsorption of sodium is overwhelmingly, its major job is to reabsorb 99% of all sodium. Erythropoietin specifically aids in the differentiation of erythroid cells, and its absence causes programmed apoptosis of the erythroid precursors. Pro-inflammatory cytokines from anything, whether it's infection or chronic inflammation, inhibit the erythropoietin producing cells and decreases the proliferation of erythroid progenitor cells. This is just a visual demonstration of erythropoietin. So when you have decreased oxygen delivery to the kidney, the peritubular cells detect the low oxygen and secrete erythropoietin to the blood. Erythropoietin acts directly on proerythroblasts in the red bone marrow. They mature into reticulocytes, form larger numbers of red blood cells, and that increases oxygen delivery to the tissues and then decreases erythropoietin expression within the kidney. There's also a very prominent role of iron in the anemia of chronic kidney disease. There's two different types of iron issues in CKD. One is an absolute iron deficiency. One is a relative iron deficiency that's caused by the chronic inflammation that prevents patients from being able to access the iron stores that they have. And erythropoietin, whether it's native or erythropoiesis stimulating agents, they won't work unless iron's available. So people eat iron, gets absorbed into the by the gut. The erythropoietin stimulates absorption of iron. The iron, once it's absorbed, binds with transferrin, which is then taken either to the bone marrow, where it can be readily accessed by the in erythropoiesis, or it's stored in the iron in the liver or in macrophages. Go ahead. So when we talk about the absolute iron deficiency that we see in chronic kidney disease, it just means that there's not enough iron stores in the body, mainly due to poor nutrition. You don't have to have chronic kidney disease to have absolute iron deficiency. I'm sure all of us have seen patients with low iron because they just drink cow's milk or something like that. It can be caused by decreased iron absorption, which is more common in chronic kidney disease. And also our patients always are losing blood because we draw blood from them all the time. So both from phlebotomy and hemodialysis, even though we go and rinse back all the blood that's in the tubing, they always lose about 50 to 100 mLs of blood that's lost with each dialysis session. A functional iron deficiency means that regardless of how much iron is stored, there's not enough iron in the body to, the body can't utilize the iron that's there. And so someone could have absolutely the right amount of iron stores if you were to go and do bone biopsies to look at the iron stores in the bone marrow, but the body can't access it. And in chronic kidney disease, that's a major issue, which is different than other forms of anemia. Hepcidin is a hormone that's involved in iron metabolism. It's made by the liver and it regulates iron absorption from the GI tract. It's what allows the body to access any stored iron. It goes and regulates the expression of ferroportin, which is a cell surface iron exporter. It's the only protein in the body that is able to go and move the iron that's within the liver cells and macrophages into the out into the blood where it can be accessed. Hepcidin is upregulated by chronic inflammation, infection, and renal failure. So patients with chronic kidney disease have much higher levels of hepcidin than other people. And with increased levels of hepcidin, you have decreased iron absorption. Iron gets stored as opposed to being utilized, being in the bone marrow where it can be utilized. And hepcidin also prevents the proliferation of the precursor cells for erythroid production. It's renally cleared. So when as your GFR goes down, your hepcidin levels go up because it's not able to be removed by the kidneys. So this is another graphic picture of hepcidin. Hepcidin is excreted by the liver. It's also, levels are go up with reduced kidney clearance. It is gone. It goes affects both the duodenum, so iron absorption within the gut, the axis of iron from liver cells and from the macrophages, and it also shortens red blood cell survival. So having high levels of hepcidin causes multiple problems within maintaining a normal hematocrit and hemoglobin. Next one, please. The last factor involved in, well, that we know about at least, in anemia is hypoxia-inducible factor, or HIF. It's a transcription factor that's a key regulator of cellular responses to hypoxia. It's a major regulator of how much erythropoietin the kidney makes. Normal oxygen levels lead to degradation of HIF so that it's not around as much. But when people are hypoxic, it stabilizes and then it leads to increased erythropoietin transcription. Next. So this just is a quick schematic about, so when people have normal amounts of oxygen, the HIF is not, that doesn't undergo hydroxylation. It's able to get ubiquitized into the cells and gets degraded. In hypoxia, it goes and it gets hydroxylated, so it's more stable and can act on the erythropoietin producing cells, in addition to multiple other cell lines that it also acts on. And goes and helps the body complete erythropoiesis by decreasing hepcidin, increasing transferrin receptors, a whole lot of downstream things. Next, please. So when we are treating people with chronic kidney disease for anemia, the first thing you do is want to maximize kidney function when you can. Most of our patients who have chronic kidney disease, their kidney function is what it is, so you can't do a whole lot about it, but trying to avoid non-steroidals, making sure they don't smoke tobacco or chew tobacco are important things to start with. We want to reduce the functional iron deficiency, though. So if we can reduce inflammation, reduce infection, that's important. Want to make sure that they have enough iron stores. We want to increase red blood cell production. And we want to you need to rule out other causes of anemia. You can't assume that it's due to erythropoietin in CKD patients. Next. There are multiple contributing factors to anemia in CKD patients other than iron deficiency and erythropoietin deficiency. 50% of CKD patients have hypocellular bone marrow. So even if they had normal iron stores and normal erythropoietin production, they just don't have enough cells to make red blood cells. Uremia is associated with a shortened red blood cell lifespan. The average red blood cell in patients without CKD is about 21 days. It can go down to 12 to 14 days in CKD patients. Nutritional deficiencies is very common in patients with chronic kidney disease, both from protein malnutrition as well as other vitamins. So we worry about B12 and folate in addition to iron deficiencies. Copper is involved in the production of erythro in red blood cells, and it's felt that hemodialysis actually removes copper from the body. So copper deficiency is is a problem. And FGF23, which is very high in CKD, is the first hormone that starts to go up when patients have diminished GFR. And FGF23 suppresses erythropoiesis and erythropoietin production, both of them. So there's multiple factors within CKD other than just iron and erythropoietin deficiencies that lead to anemia. Next, please. So when you have someone who has CKD and you determine that they're anemic, first thing, obviously, you want to do is CBC with a differential. You want to make sure there's no other cell lines that are being affected. You want to have a peripheral smear to make sure it's a normocytic and normochromic anemia. If you had a lot of schistocytes, you'd be worried about other causes. Check vitamin B12 and folate levels. Check a haptoglobin looking for hemolysis. We've been fooled by a couple of our patients who we felt initially was erythropoietin hyporesponsive, and then, they have a hemolytic anemia in addition to having CKD. Check thyroid studies, since hypothyroidism is associated with anemia, and then check iron indices. You want an iron level of ferritin, a TIBC, which is basically a way of measuring transferrin, the iron saturation, which is this serum iron divided by the total iron binding capacity, and getting a reticulocyte count. Next, please. So there's multiple treatments for anemia. Transfusions is a treatment, and it's one that was the major cornerstone in patients with CKD until the late 80s. I remember having patients come in on a monthly basis for their transfusions. Fortunately, that's not necessary anymore. In the 1950s, they used androgens. They had enough side effects that we don't use that anymore. Iron supplementation is a cornerstone of treatment. Recombinant erythropoietin and then other erythropoiesis stimulating agents are currently available. Next. So there are some advantages to transfusions. With transfusions, you have a very rapid correction. And there are some states that it's the only thing you can do. If you have someone who has severe blood loss, you have to transfuse them. If you have someone who has an amazingly low hemoglobin, if it's 4.5, you're going to have to transfuse them. You can't wait for the body to make more red blood cells, even with giving erythropoietin. And as efficient as the physiologic states that prevent iron and erythropoietin from being infected. So if you have someone who has got a chronic pyelonephritis, erythropoietin is not going to work. And then in those cases, you may have to transfuse. Next. However, transfusions come with a lot of complications. You have to worry about infections, especially viral infections, although there are some bacterial infections that can be associated with it as well. Hemosiderosis or iron overload is certainly a complication for recurrent blood transfusions. Fluid overload is a major problem in patients who have CKD and oliguria or anuria. Transfusion-associated circulatory overload is something that can happen even if you're transfusing someone while you're dialyzing them. They can still develop this sudden cardiac overload and have a cardiac arrest. You can also develop transfusion-related acute lung injuries, their transfusion reactions. And then we always worry about people who need recurrent blood transfusions, is that we're going to sensitize them and decrease the chances of them being able to get transplanted in the future. Next. Iron is a very important part of treating anemia. KDIGO recommendations for iron goals is a TSAT between 20 to 30 and ferritin levels between 100 and 500. In patients with stage 3 and stage 4 CKD, oral iron can be helpful, but it's not always. And when people are in stage 5 or on dialysis, oral iron is often not effective because of the high hepcidin levels that are associated with it. Next, please. It's not necessarily straightforward. How are you supposed to interpret the iron indices in chronic kidney disease? Ferritin is frequently already high in patients who have chronic kidney disease because of chronic inflammation. One of my patients was routinely running ferritins of about 1,200. And I didn't have a good reason for it at all. He wasn't necessarily actively infected. He wasn't on high doses of iron, although he was on kind of like maintenance iron. And we ended up having to work him up for I can never say this, hematochromatosis, which he didn't have, but he just had generalized inflammation due to his chronic kidney disease. TSATs are often low, and that's because the TIBC is often elevated in patients who have chronic kidney disease. And I have argued for years with my hematology friends who, say you have chronic kidney disease, you can't follow the TSATs because of an abnormally high TIBC. But if you have a really low TSAT, it's kind of hard to ignore it. Having a high ferritin level does not necessarily rule out benefit from iron in administration. There was a study called the DRIVE study that showed the benefit of IV iron in patients who had ferritin levels as high as 1200 without having them develop iron-associated disease. So even in your patients who have high iron, you should still consider giving them iron supplementation. Next. There are certainly complications from giving iron in people who have high ferritin or TSAT levels. We worry about iron causing infections. You can get increased damage. You can get vascular damage from oxidative stress. There is evidence that you're going to get soft tissue deposition when you give iron. There have been some studies, animal studies, that have shown iron deposition in brains in mice who are given high levels of iron. And anaphylaxis is something that people can get from IV iron, especially iron dextran. Instances between 24 to 68 cases in 100,000 people getting it. Next, okay. The pivotal trial is a randomized trial that was comparing proactive high dose IV iron, so giving it before there was even a problem, versus giving low dose IV iron in people who were not responding to erythropoietin. This is all in hemodialysis patients. People were given IV iron even if they had a TSAT that was 40%, and a ferritin up to 700. They found that the patients who were given this high dose IV iron had a lower incidence of death, lower incidence of hospitalization, and lower hospitalization of non-fatal cardiovascular events. They required fewer transfusions and had less need for erythropoietin as well. There wasn't any increased risk of infection in the two arms. So given the IV iron did not go and cause more infection versus the people who got low dose IV iron. Next, please. We also had the advantage that there is a new generation of IV iron, so iron dextran is no longer the only potential IV iron available. The key advantage to these new generations is that they have a carbohydrate shell that prevents the iron just from leaking out when you administer it, so it's a more controlled administration of it. And you can give high enough doses of iron that you can completely replete someone's iron stores from 1 to 2 doses. So in patients who are on hemodialysis or on peritoneal dialysis, giving IV iron is probably the treatment of choice as opposed to oral iron. Next. There are other medications that we can use to treat the anemia and chronic kidney disease. Obviously, erythropoietin, recombinant human erythropoietin is the most common one that we use. There are also continuous erythropoiesis receptor activators that are newer, and we're just starting to use those. Next. So the goals of erythropoietin treatment is to reach a hemoglobin of 11.5 to between 10 and 11.5 grams per deciliter. Higher levels of hemoglobin associated with greater side effects. They did do a study back in the 90s comparing people who had a hemoglobin between 10 to 12 versus people who had a hemoglobin between 12 to 14, so a more normal hemoglobin. The patients with the higher hemoglobins had increased mortality, increased clots, increase adverse cardiovascular events, and increase cerebral vascular events. So we don't want to go and really push. You can go back. Next one. And these are the graphs used in one of the trials looking at it, where the high hemoglobins, which is the light blue, had a lot more, had higher instances of having a negative event, which is the graph on the right. Next. So the ESAs, or erythropoiesis stimulating agents. The most common ones we use are erythropoietin, darbepoetin. There are a whole lot of other ones available, not necessarily in the United States, because we take a long time to approve things. They're all produced by recombinant DNA technologies. Erythropoietin and darbepoetin act in the same way. Darbepoetin has an extra molecule attached to it, so it has a longer half-life, so it allows less frequent dosing. It's also thicker, so it hurts more. So if you're giving it by injection, it's not necessarily as well tolerated. Next. There are adverse effects of erythropoietin. Causes hypertension, and that's not just related to hemoglobin. I mean, it makes sense to think that if you have thinner blood, your blood pressure will be low, and then as your hemoglobin increases, there's going to be increased blood pressures. But by itself, erythropoietin can stimulate vasoconstriction and hypertension. Back when erythropoietin was amazingly expensive, we tended to never want to throw anything out from the vial, so you just kind of like round up. And it ended up that some people would develop really significant hypertension, so you ended up having to add more medications to control the blood pressure. So you want to be judicious in your dosing. There's an increased risk of malignancy in erythropoietin. That was and that was one of the findings in some trials where they were going for higher hemoglobins, was that people got more cancers, and that's because some tumors actually express erythropoietin on their surface, and so you're stimulating proliferation of the cancer cells. Some people are allergic to it, and a fortunately very rare complication is that some people get antibodies directly against erythropoietin, and so regardless of how much erythropoietin you give or what variation of erythropoietin you provide, they end up having a pure red cell anemia that is transfusion dependent. Next. Epoetin alpha aplex is it's specifically erythropoietin, that's human erythropoietin. It was approved by the FDA in 2018. It's been used in Europe, in Asia since 2007. It's similar in effectiveness to epoetin. So it's using it as more what's available to you specifically. Next, please. The continuous erythropoiesis receptor activators are just starting to be used. It's basically a longer acting ESA, so you can give it once a month. And it's formulated so it just lasts longer. Next. One of the more exciting things that's coming up are the HIF prolyl hydroxylase inhibitors. These they stabilize HIF levels and increases erythropoietin production. It's very, very effective in people who are hyporesponsive to erythropoietin and the other ESAs. This can be really beneficial. It acts by decreasing hepcidin levels, so you have better iron absorption, and erythropoietin isn't blocked. You can only give it in dialysis patients. The major concern with it, and it's also oral. So HIF contributes to angiogenesis, so there's concern in people who have retinopathy, specifically diabetics, that it may worsen their retinopathy. It increases cyst formation in people who have ADPKD, and HIF affects a whole lot of different genes, and so there's some concern of what's going to happen in 5 to 10 years if someone's been on it chronically, and we don't have that information yet. And so in pediatrics, we don't use this. Next. So this is the draft KDIGO recommendations for treatment of anemia. It just came out in 2025. So it's basically, so in patients with chronic kidney disease who are anemic, you first perform the basic labs that we discussed. If the iron deficiency is severe, then you need to look for other potential causes. So you also refer to gastroenterologist for endoscopy, concern of is there something some urologic bleeding, whether or not there could be a malignancy. That's the first step. You then go and add check for iron deficiency and be very aggressive about treating it. In patients who have stage 3 or 4 chronic kidney disease, really pushing oral iron can be effective in controlling it, but you're going to need to consider IV iron in patients with stage 5 or dialysis dependent anemia. And if you don't have iron deficiency, that's unlikely, then you look at all the other nutritional factors and liver functions. And then if you do have iron deficiency, you give iron and you start the ESAs. Next. And this is just the European version of the KDIGO ones. All right. Thank you very much. I talked really quickly. I'm sorry.
I think this was great, Melissa. Thank you again for sharing your experience and going over in detail about management of anemia and the pathophysiology of anemia when it comes to chronic kidney disease state. I will stop sharing at this point, and then we do have some questions in the chat, and we will go over them one by one. And let me start with first Dr. Anil about genetic testing, and this is more in relation to C3GN. So the attendee is asking, so in case if the phenotype of the diagnosis is unclear, say for example, a patient has weak mesangial C3, it could be a resolving glomerulonephritis or a C3 glomerulonephritis. Other features would be equivocal with no EM diagnosis available or anti-complement antibodies available. So definitely we don't have too much information, to come to a clear diagnosis of C3GN. So now in these cases, what would be the role of genetic testing, considering the cost, considering, how would we approach such a case? That's what we would want to hear from you.
Yeah, so always as C3 dominant glomerulonephritis, I always say condom, whether it's a post-infectious or is it a really a genetic or alternative complement pathway-mediated disease. But usually it all depends on when you do the biopsy in the setting of PIGN. If you do early in the course of illness, you are going to get a immune complex-mediated setting where you have the IgG-C3. And when you do it later, much later in the course of disease, you may get a isolated C3 deposition. But here I will always probably place the importance of the clinical profile of the patients. If proteinuria is improving, the renal function is improving, because technically if it's a PIGN, everything should normalize within 12 weeks, including the C3. So that will be my start point for further investigation. If everything is okay, I will not do anything further. Else, if the proteinuria is persisting, the renal function is worsening as opposed to improving, then you are probably thinking of a C3GN. Your option is probably to do a repeat biopsy to check what is actually happening, or or a genetic testing, because genetic testing is not going to give you the answers always. Especially in the setting of C3GN, that's what we have noticed. Being an autosomal dominant, most of the variants, interpretation becomes difficult, and you may go back to rely on your biopsy to clinically correlate. But a weak mesangial is not something suggestive of a C3GN, because they put it as a weak mesangial. It has to be of an intense staining or a 2-order magnitude compared to the other immunoglobulin profile. So this is how I would approach. So look at normalization of C3 and normalization of clinical features at the end of 12 weeks.
Yeah. No, I think I totally agree. And we would follow a very similar kind of approach here also. If C3 is persistently low at 12 weeks, then is the time you would start investigating. And definitely, genetic testing is one of the ways you can look into it, uh, depending on the availability, depending on the cost, and plus having a repeat biopsy. I think that would definitely let us know what's going on. Now, how easily is C3 genetic testings available? And I know you are the expert in this, and you get a lot of referrals, and that's the question I'm sure other attendees would also have. And can you please share your experience about that?
Yeah, I mean, genetic testing is much more accessible and affordable than what was a few years ago. But what we lack is actually the other ancillary testing for the complementary factors. Like we don't have an access to C3 nephritic factor assay, which may be indicated, especially if you have a C3 dominant gene. We don't have assay for AH50 or a CH50 assay. But genetic, yes, we have. The other thing is not routinely done is the electron microscopy to look at dense, intramembranous deposit, especially because of the cost. And very few centers in India actually do EM. Probably the genetic testing has become much more accessible because of the private public partnership, where we have a lot of private players in this field.
Yeah, no, definitely that's good to know. And maybe I'll switch to Dr. Gregory for one of the questions. And I think one of the questions is, do you recommend erythropoietin in acute kidney injury states as a temporary measure of increasing hemoglobin level?
If it's truly so if it depends. It's considered to be AKI for 3 months, right? So if you're having AKI for 6 weeks, I would probably start it. Erythropoietin takes 4 to 6 weeks to work. So if you have someone who is coming in with an acute injury, the erythropoietin is not going to be helpful for a long period of time. And you probably are going to have a lot of inflammation going on. So even if you give it, it's not going to be responsive. So I don't give erythropoietin and AKI unless I feel strongly that it's likely going to become CKD, and then I would start it. But certainly if someone comes in with multi-organ system failure, I would not be starting it at that point, because it's not going to work because of the chronic inflammation or the acute inflammation.
No, thank you. And I'll go back to Dr. Anil. Do you recommend genetic screening both for baby and parents if baby has cloacal anomaly and parents are keen in knowing the recurrence rate in future pregnancy? And if so, is there a CACUT panel that you do?
The CACUT in general does not usually cover the cloacal anomaly. I mean, the cloacal anomaly is usually setting off a syndromic manifestation. It could be a VACTERL, it could be just a bladder extrophy, or only purely a cloacal abnormality. Like in VACTERL, there are genes identified, but I would best suggest to get in touch with a genetic specialist to decide whether a chromosomal karyotyping, especially in a syndromic manifestation, would be more appropriate first step, or to go for an exome sequencing, because there are monogenic causes that has been identified in VACTERL. But the yield is quite low. That is the other thing that needs to be counseled, that you're not going to give the answers all the time. But in short, a CACUT panel may not cover all the cloacal anomalies.
Oh, that's great. Thank you. I'll go back to Dr. Gregory. When to consider erythropoietin resistance? And if you could also comment on, pure red cell aplasia that you be maybe noticing, especially, I think we use ASARB so much. And do you find challenging when you're using ASARB and then you see at the same time anemia? What is your experience, about epogen resistance in our CKD population?
Right. So if I have almost all of my patients are on ASARBs. If I have someone who's on an ACE and they have an unexpected decrease in their hemoglobin, so if they've been kind of riding at about 10.5 and then suddenly they drop to 9, my first action is I switch the ACE to an ARB, because there really is a ACE inhibitors can cause anemia. ARBs don't do them as much. And then I wait a couple months. And this is obviously assuming that the hemoglobin is not like debilitatingly low. If the hemoglobin goes back to their baseline, then I just continue with EPO as if I'm using it. See, there's like 4 questions in that, Amrish.
Okay. So one was about the EPO resistance, I think.
So if someone is getting a reasonable dose of EPO, and I know that they're getting it, I know in our peritoneal dialysis population, we sometimes have patients actually come in and we give them the injection because we're not sure that it's happening at home. So you have to be comfortable that your patient's getting their erythropoietin. Make sure that you're comfortable that their iron stores are replete, and that they're getting a good dose of EPO. And if all those things are true and they're still not responding, then you have to consider them to be erythropoietin resistant. If you're worrying that they are going to have pure red cell aplasia, ideally you'd get erythropoietin antibodies to prove that that's what it is and that's the cause of it. But I usually wait at least 6 months before I make that diagnosis because there's so many other factors.
Yeah, no, sounds great. Dr. Anil, any thoughts from your side on EPO resistance?
I mean, I agree with Dr. Gregory. I mean, we do evaluate first for the compliance. So that is very notorious, especially in our setting, financial implications, I mean, which is seen as an EPO resistance. When we look for non-iron deficiency, other causes of anemia, hyperparathyroidism, just as mentioned. Sometimes we are changed from alpha to beta, and that has given, I'm not sure how, but it has sometimes helped us to get a better response. But yes, we do see this occasionally, the EPO resistance. And also a point is of the relative iron deficiency. Sometimes the iron stores are not enough to, to accelerate that hemoglobin production. So just bumping up the iron to a higher level, although we technically take between 100 and 500 as you're okay, and 500 to 1000 as a definitive insufficiency. Maybe pushing that up higher might help.
Yeah, I agree with that comment, absolutely. Because if the more in our CKD clinic, I'm really quite aggressive giving oral iron, and everyone's iron, even if their hemoglobins are normal, I start them on iron if they have a lowish ferritin or a lowish iron saturation. And our use of erythropoietin in this patient population, I don't have we've not had any patient with stage 3 CKD on EPO for 15 years. The number of people with stage 4 on EPO is probably about 3%. And for most of the patients I have are the stage 5, and that's about 20% of them. So it's much lower than a lot of the published ones. And it's because we push iron like crazy. So you're absolutely right.
Yeah. No, I think that's great discussion. And there are a few more questions in the chat, but I don't know if we would have time for that because we also have a polling session that we need to do. Dr. Clavany, should we go ahead with the polling session? Okay, do we have time to answer a few more questions?
Like, if Dr. Gregory is okay, like we can take up a few more questions. Sure. And then we will move on for the polling session.
Okay, sounds good. So next question is related to TSATs and ferritin, and I think it is a little bit confusing topic. So if the TSAT is less than 20% or is around 20% and ferritin is high, maybe 800s, would IV iron still be beneficial? And the attendee is asking what should be the upper limit for serum ferritin before deciding IV iron would be beneficial or not. So basically, what are the indications of IV iron? When do we use it?
Absolutely, it's a hard question to answer. In an ideal situation, and I recognize that none of us live in an ideal situation, you'd get an MRI of their liver to look for iron deposition, which is what I did with my patient who had a ferritin of 1200 and iron stores at like 23%. A TSAT of 23%. I think the pivotal study and the DRIVE studies, though, are very reassuring in that you can push it by, if you give a single dose of IV iron and they respond, so their reticulocyte increases, their reticulocyte count increases, and their hemoglobin improves, then continuing to get, to give IV iron until you're, for 1 or 2 doses, is unlikely to cause harm and could cause benefit. So if you have someone if someone had a lowish TSAT, a high ferritin, and a low hemoglobin, I would probably give them 1 dose of IV iron to see, and then assess if it worked, because the chances of my putting them into, hemosiderosis is going to be really low from a single dose. But then you have to reassess after you give it.
Yeah, sounds great. And the flip side of the question is, do you need to give IV, or do you need to give iron concomitantly with epogen, even if the iron studies are normal? So
Yes.
is iron a must with epogen?
Yes, you do. Because if you don't have the iron, the EPO's not going to work. And so if you go and wait for your hemoglobin to start falling more, if you start waiting for your erythropoietin to not work because your iron stores fall, then you're just behind the EPO. I wouldn't give them max amounts. I'd give them like 2 mg per kg or 3 mg per kg. I wouldn't give them a huge amount, but I would keep them on iron. Also, people hate taking iron. So giving them an excuse not to take it, I think, is a bad idea.
Yeah. No, I think these are some great questions and very practical questions. So I'm glad that attendees are asking these, and these are really great questions. So thank you for a wonderful question and answer session. And I think we will move ahead with the polling session. Dr. Anil and Dr. Gregory, if you would like to stay back, please do. But again, thank you very much for your excellent talks and excellent discussion on the topics. We really appreciate that. Thank you so much.
Thank you for the invitation. Thank you for the invitation.
Thank you both, Dr. Kalai and Dr. Amrish.
Thank you. Thank you, sir. Thank you, Dr. Gregory.
So these are the instructions for the polling sessions. Participants are requested to enter proper email ID and contact number during the process of registration for the ease of future communication. Total polling sessions will be 6, every Wednesday and Saturday. The first and the last session do not have any polling sessions. Each polling session will have 10 questions, and it's mandatory to answer all of them. Total duration is 5 minutes for the polling session, and we'll have 4 star questions in each session, and star questions are taken into consideration in case of tie. Cumulative score of all 6 polling sessions will be taken as the final mark for selecting the winners. We have 3 prizes. Only trainees are allowed to participate in the polling session. Request all the participants to log in on time using a bigger screen for easy viewing of questions. For better view in iPad or tab, use landscape mode. Once you log into the webinar, you can avail the polling session in the same link during the webinar session. Can we go ahead with the questions, please? And can we have the timer as well?
We are left with 2 more minutes. One more minute left. Last 10 seconds. Can we stop the polls?
Okay, this brings to the end of the session. Again, thank you all for attending. I hope you learned a lot, and we will see you again on Wednesday. Again, we have some international and national speakers that day. Looking forward to seeing you on Wednesday. Dr. Kalamani, anything else you would like to add?
That's it.
Okay, thank you, everyone. Bye-bye.
Yeah, bye-bye.